Hi, everybody. Welcome back to Irish Hospice Foundation Advanced Care Planning webinar series. My name is Valerie Smith. I'm the Public Engagement Lead at Irish Hospice Foundation, leading on Think Ahead, our Advanced Care Planning program. I'm joined today by the fabulous Mary Ferns, Carew Regional Lead in the Dublin area, who is watching the chat and all the tech for me. So thank you again, Mary. Webinar 3, Future-Proof Your Health. Today we'll be talking about those basic treatment options. This is Think Ahead. You may have seen it before. If you've been attending these webinars, you certainly have. If you see this around, Think Ahead is the Irish Hospice Foundation Advanced Care Planning Program. We have been specializing in the healthcare directives, but also how we prepare for care, our own care, and our own making sure our own wishes are known for the future. This is a 4-part webinar series. You may have seen or attended the first 2 webinars on your Market Set Plan Ahead. Just started you off with what resources you might want to start gathering, how you start thinking about planning ahead, and the basics of what it is. Last month, we also discussed helping others plan ahead, so how we start having those conversations and some different ways that we can support people. Those 2 webinars should be available by the end of today. By this same link here. They're also available on our YouTube and on Vimeo. We're here at Basic Treatment Options Explained. Next week is our final of this 4-part series with Build Your Dream Team, choosing supporters to help you thrive. We'll also be talking about enduring power of attorney and the types of support there that you can seek and types of decisions there. So you are invited to scan and register for that last one as well. Anybody who's registering will receive the recordings of these videos, as well as additional resources, like the worksheets that we're covering. Today's agenda will have a very quick review to bring everybody back onto the same page. It's been a few weeks since we've been together. We'll discuss what is an advanced healthcare directive, how we refuse and consent to treatments, but the real chunk of today is reviewing what those common end-of-life treatments are that we can think about if we want to specifically consent to them or refuse them. The resources that we have for you today, Mary's putting a link in the chat to the materials folder that has the Advanced Healthcare Directive from Irish Hospice Foundation. It also has, we haven't added it in there, but it will have at the end of today, the Decision Support Service Advanced Healthcare Directive. And it has worksheet 5, which provides some prompts for thinking about what you want for yourself. So quickly reviewing webinars 1 and 2. Advanced or future care planning is thinking about, talking about, and telling others what we want for our own care in the future. Think, talk, tell. This is future or advanced care planning. For this series, we have been covering some of these options, including the Think Ahead Planning Pack and the Enduring Power of Attorney. We discussed the personal wishes and care plan, in large part in week 1 and 2. Today we're discussing the Advanced Healthcare Directive. And then we've been going over the basics of getting into that decision support service to create the enduring powers of attorney so that we can make our finance and property decisions as well as our personal welfare decisions. And we'll be reviewing those more in detail next week. Capacity. We have to have capacity to make these decisions. So as a reminder, if you need to make a decision, can you understand your choices, compare those choices, choose one of them, and then explain that to another person? That means you, in basic terms, that means you have capacity to make a decision for the future. There's a lot more on this in webinar 1, so I would refer you back to that if you'd like to go over this again. Last month, we started discussing more about supporters in less formal arrangements, helping people get into the system, helping people start to have these conversations. But supporters are considered anybody who helps a person to think about their choices, make a decision, communicate that decision or act on it. So again, last week we talked about helping people start the conversations, helping people get into the systems, and next week we'll do a lot more around acting on those decisions and who we choose to put into that role. We've talked about different types of support, like gathering information, talking with people, or providing technical support. And you've had a bit of homework over these last 4 weeks, should you choose to accept it, including reviewing different documents and starting to think about what obstacles you might be facing in planning ahead or why you might plan ahead. So you've been given different bits of homework to just sort of start reviewing. All completely up to you on when you choose to do so. We're here on step 3, preparing your advanced healthcare directive. We'll be using the Think Ahead Planning Pack today for this, in particular, my Advanced Healthcare Directive. Again, this is in the webinar folder that has been shared with you. It'll be shared in the emails going out afterwards as well. My Advanced Healthcare Directive with Irish Hospice Foundation is currently in its 2nd edition in print. We are reviewing those documents at the moment and updating them for language, but none of the updates that we've previously had or will have into the future affect its legality. It's just to make it as easy to understand as possible, while understanding that this is a complicated document. It requires certain types of professional and legal language that we have to keep in there. And there's a lot of information included in here, including step-by-step how to complete these documents. So a person is allowed to make an advanced healthcare directive on their own. We just don't recommend that you do so. We do recommend that people talk with others and work on these things together because they can be quite overwhelming as well. We'll go through it in detail today. We'll have this recording for you at all times, but all the information is in the Advanced Healthcare Directive as well. So the sound should be shared on this. If it isn't, somebody just might give me a little shout, Mary, if you can't hear anything, but I think we should be set for watching this short video.
We don't know what our future holds. But wouldn't it be nice to know our wishes and decisions about our own care will be heard and respected? With an Advanced Healthcare Directive, you can record your future healthcare decisions. If a time comes when you're unable to make or communicate decisions, your preferences and choices will be known. In an Advanced Healthcare Directive, you can consent to or refuse future treatment, including preventative, therapeutic, and life-sustaining treatments. Talking to your GP or medical professional can help you understand what options you have. You can appoint 1 or 2 people as your designated healthcare representatives. They will follow and make your choices and preferences known in situations when you might not be able to. Once an Advanced Healthcare Directive is signed and witnessed, it is legally binding. Make sure to share copies with important people. If it is ever needed, you'll have your say in your treatment.
That video is also included in the folder. So you have that. You can share that with friends, with family, with patients, with clients as you need. So for summary, in an Advanced Healthcare Directive, you can do 3 things. You can refuse treatments, consent to treatments, and appoint a supporter, a designated healthcare representative. It can be a written document, but it could also be voice or video recorded. We'll be talking mainly about these first 2, refusing or consenting to treatments today, and appointing people next week who would act on those decisions. When we're talking about treatments, we really mean any type of treatment you can include in these documents. Any type of what they call, medical intervention to cure an illness, to prevent anything, to diagnose, to alleviate symptoms, or to prolong life. You can include treatments for physical health as well as for mental health. For today, we're really only talking about the physical health treatments for end of life primarily, but you can have documents for other other situations, other illnesses as well. For example, treatments that can be included are chemotherapy, surgery, medications, blood transfusions, biopsies. So we won't go into all of these kind of things today, but just to give you the breadth of what can be included in an advanced healthcare directive. So these can be what we'll be discussing today, the end of life treatments that are maybe more or less common, but they can all be modified, and all of these can be made to your own needs. So if there is something that you personally are experiencing, going through, you have a diagnosis of, there may be other treatments that you would wish to include within your advanced healthcare directive. There's no way that we could cover all of them, especially in less than an hour, but you can include, in theory, any type of treatment here. What we'll do is we'll discuss how you can refuse and consent to treatments, and then we'll go into a few examples using the different treatments that we'll be covering. So refusing treatments, again, just for physical health, not for mental health. Any refusals that you include in your advanced healthcare directive is legally valid. So if I've refused anything, healthcare professionals must follow those refusals, and my supporters, anybody that I've named to act on my behalf around my healthcare decisions, also must follow my refusals. The limits to this are basically that we always receive basic care. And I include this because people sometimes think if I'm refusing treatments that I won't be receiving the care that I need at end of life. We always receive basic care, shelter, warmth, hygiene, the offer of food and water. These aren't medical interventions. These are basic care. So we always receive this even if there's a certain treatment that we've decided we don't want. When we're refusing a treatment, we have to follow certain guidelines to make it as clear as possible for people to follow. First, we have to name the specific treatment that we're refusing. And then we have to describe those circumstances. The last thing we have to do is declare with a yes or no statement, would we still refuse this treatment even if our life is at risk? So 3 things to refuse a treatment: naming the treatment, describing any circumstances around that refusal, and then yes or no, would you refuse even if your life is at risk? This is what our document looks like in the Think Ahead Planning Pack. Bring that up closer a little bit for you there. So you should see that there's a box that asks, what is the specific treatment you do not wish to receive? What are those circumstances, if any? And then yes or no, do I refuse even if my life is at risk? As I've said, we're reviewing these documents right now. They're in edits phase, and we'll line up especially that last box to match the decision support service. The decision support service does have a downloadable form. Again, we'll have it in the webinar folder. And this has a very easy to read tick box. I would refuse this treatment even if my life is at risk, yes or no. So we'll match that in the next edition. But just by describing what it is, any circumstances that would apply to, and yes or no, does this apply if my life is at risk? Again, we'll be going through considerations for different examples of this in just a few minutes. Similarly, you can consent to treatments. This is really what we're talking about today. What can you refuse to and what can you consent to? So for physical health, it's slightly different though. If your healthcare team thinks and recommends that a treatment is appropriate and that treatment's available, then your consent would be valid. So a healthcare team would have to follow my consent, and thus my supporters must follow my consent as well. A treatment that I have consented to might not be appropriate. It might not be available. It might cause more pain and suffering, and my healthcare team wouldn't recommend it. In these cases, I wouldn't receive the treatment even if I've consented to it. So for example, I may have consented to ventilation, a breathing machine, but if I don't need that treatment, if that's not what I need to recover in this moment, my healthcare team may not recommend that treatment and I wouldn't receive that treatment. So while I can refuse anything and they have to follow that refusal word for word, what I've consented to is saying, if this is the appropriate treatment, if this treatment is available, then I would consent to this treatment. And in that case, my team and my supporters follow my consent. The caveats to consent are that it must be legal in this country. There's no sort of guarantee of travel to a different country to receive a treatment. Um, and that certain exclusions exist, including, for example, medical trials. We do get questions here and there about treatments that aren't yet legal in this country, or we can't speak to what will happen with those in the future. All we can say is that if the treatment is legal in this country now and you've given consent to it, it's appropriate, it's available, you're very likely to receive that treatment. There will be exclusions such as medical trials. When you're consenting to treatment, very similar to as the above, you'll be naming the specific treatment and describing those circumstances. So similarly to refusing treatment, you have to name it and describe the circumstances. You don't need to put that last box in there if you consent to treatment, even if your life is at risk. It's not applicable in this sense. Our documents look like this. One box where you describe the treatment and any circumstances where it might apply. And the decision support service form has two separate boxes, but the same question. What is the treatment and what are the circumstances for that treatment? So this is where we get to the question that has prompted this whole entire webinar. Every time that we lead these trainings out in the community, the question becomes, if I'm well or I don't have a specific diagnosis, if I don't know what's coming down the line for me, what should I include in my healthcare directive? We're going to go over some common treatment options today. And as a reminder, we're not advising clinically anybody to do or not to do any of these things. We're just going over what these common treatment options are, some of them. And the first thing that I want to bring to your attention is palliative care. A lot of people think palliative care is only end-of-life care, or it's only available to people receiving who have a cancer diagnosis. But that's not true. Palliative care is available to all people with a life-limiting condition or life-limiting illness. And palliative care treats the whole person. So this looks after your physical well-being as well as your psychological, your emotional, your spiritual well-being. In many cases, looking after your social well-being and helping you to stay connected with people. And the aim of palliative care is quality of life. So how can different treatments or different types of support and alternative therapies, even like the arts, help a person to maintain or improve or support their quality of life? Palliative care is generally offered across all systems at the level 1, what's called level 1. But as people move through illness, they may require specialist palliative care as well. And that's where a specialist team can step in and provide more guided support for a person. And what we do know is that a lot of patients want specialist palliative care before healthcare teams are often ready to bring that into a person's treatment. But we know that when a person receives palliative care from early days, even if that's a light touch from early days in a treatment, that if that illness goes toward end of life, all of those measures of quality of life are higher if they've been receiving palliative care. We have a document that's in the webinar folder, palliative care. What is it and who is it for? That will provide more information on palliative care. And we are very grateful for the National Adult Palliative Care Policy, which we will be part of implementing at the generalist level. So just a little shout out there for palliative care. As I said, we don't offer any clinical advice, so the specific treatments that we're going into now, we're not recommending that you refuse them or consent to them or even acknowledge them, but you can consult your own medical team and how these treatments may or may not work for you and make that decision yourself. So even if you give us a call later and you want to know in your specific case, what should I do? We can't offer you that clinical advice. The first treatment, and this isn't a treatment that's only available to people at end of life, but the first treatment that we're covering is pain and symptom management, including morphine and other opioids, but lots of treatments are available for pain and symptom management outside of these as well. But I really want to cover with this, particularly this idea that people have around morphine or pain. Um, what it does is it manages pain symptoms so that a person is comfortable. But morphine and other pain management do not cause death. And there's a big fear that people have that if they're on morphine or if their loved one is on morphine, that this will hasten death, and it just isn't the case. Morphine and other pain management and symptom management methods can be used to make a person comfortable. In palliative care, one of the greatest obstacles to overcome worldwide is that people are dying without that pain and symptom management. They're dying in pain. And we just don't have to allow people to suffer anymore. And morphine and other opioids, as well as other types of symptom management, can really support a person to live well even at end of life, and to be out of that suffering, and even be, in many cases, very active and social during those last days and weeks. Morphine and other pain medications do not cause death. That's the one takeaway I'd like you to have from this slide. The next treatment option that we're going to describe is deactivating an ICD. An ICD is an implanted cardioverter defibrillator. Excuse me for not having the other name at hand, the CRDT. But these are both devices that are implanted that help to monitor the heart, help the heart to beat efficiently, and give a little electric shock if that rhythm is life-threatening. This is something that people can live with for a very long time and can live with very well for a long time. However, what we have been working with teams on is helping people to know that as they reach end of life, they can deactivate this if they so choose, because having those little shocks to the heart as a person is going through the dying process can be quite uncomfortable for some people. So it is an option for people who have an ICD or a CRDT to deactivate those to make them more comfortable as they're at end of life. Deactivating an ICD, deactivating a CRDT does not cause death. However, if the heart does go into a rhythm that's life-threatening, the ICD will not shock the heart and the person may move into the dying process. But deactivating this can make a person more comfortable. We will have more information on this coming out at some point this year. I think in the coming months. Our team and the Dying Well at Home team has been working very closely to provide more information for the public on this. The next few treatments that we're looking at are more commonly what we would refer to as a life-sustaining treatment. When we're talking about life-sustaining treatment, we're talking about a treatment or a technology, including machine-aided technology, a procedure or medication. And what it does is it prolongs life, generally by doing some of the body's work for us, by providing some of the work of the organs for us. Most of the time, they're not a cure on their own for an underlying illness or an injury, but they can be used in many cases to support other treatments. There are times in your life where it may be perfectly reasonable to receive a life-sustaining treatment, and then times in your life where if a treatment or a cure is not available, that you may not wish to continue or to receive that treatment. So it's just about thinking under what circumstances would I want this type of treatment, and are there anywhere I would not want this type of treatment? Stopping these treatments or refusing these treatments may mean that your body begins the dying process. Depending on what the treatment is, that could be a quicker process than other times. So I'll give you a few examples here. A first common end-of-life or life-sustaining treatment is ventilation. The technical term is mechanical ventilation. And what it does is it helps you to breathe. So it brings oxygen into your body and it removes carbon dioxide from your body. Ventilation can be an excellent treatment for people who are, or support treatment for people who are living with respiratory illnesses, or you might find this after you've come out of surgery, any type of reason you might receive ventilation in a supportive way. And there may be times where ventilation is keeping the body alive when there isn't a likelihood to recover or to, for example, regain consciousness otherwise. So ventilation is I think, a good example of when it's important to think about under certain circumstances, I very much would want ventilation, and under others, I might not. So if this is the machine, or sorry, the treatment that is prolonging life, but not necessarily prolonging quality of life, or not necessarily bringing, helping a person to come back into consciousness, whatever that might be for you, you might decide at that point, I would not wish this treatment. Or you could decide that you want this treatment no matter what. So for example, I often include this for my own advanced healthcare directive, because I have family that lives far away, that I would request, or I would consent to ventilation if it allows family time to come and be with me at end of life, at which point I could stop treatment. So there's just different ways that you can describe when you would consent to treatment and under what circumstances you might refuse it. A next treatment at end of life is tube feeding or nutrition. This has different terms, technical terms, depending on how this is being administered. And it makes sure that the patient, has the right nutrition to live, enough nutrition to live. So if they cannot chew or swallow or absorb nutrients. Again, this treatment can be perfectly a great treatment and supportive for a person who isn't able to absorb nutrients and needs this to live well. For other people, there may come to a point where they're receiving nutrition, but it's not aiding in recovery, or not aiding a person to live well, and you can decide at that point, would you or would you not want to continue with this treatment. So tube feeding, similar to IV fluids, which is our next treatment that you can think about as well, IV hydration. Both of these can be used with people at end of life when they're no longer eating or drinking, eating food or drinking fluids. And so with IV fluids or hydration, if a person can't drink water or swallow water, they may be provided with IV hydration in order to provide them with enough to live. With both of these, I will note that as people reach end of life, they will often always stop eating and stop drinking liquids in the days or weeks leading up to their death. And it is a natural part of that dying process. In some cases, people are provided with nutrition in order to keep them living and prolonging life. They might be provided with hydration in order to keep them living and prolonging life. But they'll always be looked after, especially with hydration, around providing moisture and things to the lips and the mouth so that people are not uncomfortable. But you could decide at some point that there may come a point where you may not wish to receive nutrition or hydration if it is prolonging life. Again, if it's not providing with the quality of life that you would wish to be having at that time. But all of these, ventilation, tube feeding, hydration, can all be supportive, recovering from surgery, or preparing for surgery, or in living day-to-day life in other times of your life as well. So really dependent on your own circumstances, I would urge you to think about these 3 life-sustaining treatments, and if they are what you would want for yourself, and at what point you would want them, and at what point you would not want them. This is a little bit more specific, but because we do work with a lot of renal units. We're including this here today as well, around kidney dialysis. Again, different ways that a person can receive dialysis, so there's different names for it. And what it does is it filters your blood when your kidneys are not able to do so. It doesn't stop the kidneys from deteriorating. So again, it isn't that cure, but it can be very supportive to people awaiting, for example, awaiting a transplant or going through other types of treatment. There may come a point for people when they no longer wish to receive this treatment or they don't wish to start this treatment. And having this discussion around and thinking around what it is that you want for yourself, at what point you would consent to that, and at what point you would not consent to that treatment can be very helpful in advance for people at the beginning of these treatments to decide what that quality of life means and at what point they would not continue with treatment. Stopping with kidney dialysis would mean that the body is not able to filter out those we'll say toxins, and the body would eventually begin to begin the dying process. So these are more or less some common treatments that a person can think about for end of life. If you don't have a diagnosis, these are things that tend to be offered to people as treatments more often than others. If you have a diagnosis, I would also encourage you to speak with your consultant if you're living with a life-limiting condition about the specifics of your own treatment as well. We do have one more that we're going to cover today, CPR. I do want to give a little content warning on this. I think it may be uncomfortable for some attendees, and the reason I say that is because it took me a little bit of time to figure out how to present this as well in a way. We're not as comfortable talking about the realities of CPR. And so I just want to let people know that there are some maybe stark figures, and we're going to explore this topic for the next few minutes. I encourage you to stay here, but if you need to take a little walk away from the screen, this will be here when you're ready. So what is CPR? CPR is cardiopulmonary resuscitation. Cardio meaning the heart, pulmonary the lungs, resuscitation, kind of bringing back, arousing. You may have seen those defibrillators out in the street, in the old phone booths, with symbols like this on it. That's part of CPR. What CPR does is it attempts to restore blood flow if the heart stops beating. It can also attempt to bring oxygen back into the lungs. And it uses some or all of these different treatments. Chest compression, that's what we mostly think of when we think of, that song Staying Alive. Chest compressions. Electric shocks to the heart, that's using those defibrillators. It can include injecting medicine, and it can also include breathing machines. And often, for it to be successful, it will include some or all of these things. So resuscitate means to revivify, to bring back to life. And I say that because some of the other treatments that we were discussing earlier are treatments that keep us alive while we're living. And this is from the other side. It's to bring back. It was designed for people who are younger, relatively healthy, and what we might call a reversible death, a sudden event by people who do not have other underlying conditions. And like I had mentioned on the last slide, to be successful, it usually includes multiple different types of treatment. So the compressions, ventilation, the breathing, as well as defibrillation. The stark figures start here, and I just want to point out that I think most of us have seen this idea of CPR happening in a hospital. We've seen it on telly, we've seen it on shows, and we think it works all the time. And I just want to point out that it just doesn't work all the time, let alone most of the time. CPR starts after the heart stops or after our breathing has stopped. And out of about 100 people who will receive CPR in hospital, most of them will not be successfully resuscitated. The numbers are hard to pin down. So we're working with numbers out of the United States for this one. But most people will not be resuscitated when they receive CPR in the hospital. The numbers are lower on the street, but we'll talk about sort of the things that we know we can include in our documents there. So really talking about hospital. CPR can also prolong suffering. So of those 15 people who are resuscitated, there can be lasting injuries as well, including broken ribs or punctured organs that require additional treatments. And depending on how long a person has not been receiving oxygen to the brain or blood flow through the heart, they may have brain damage, and that can include irreversible states. So I know that this is stark and can be uncomfortable, but it's important to understand when we're consenting to a treatment, what the some of the outcomes of those treatments might be. And that's why I really want to highlight some of these figures. And like we said, it was designed for people who are younger, who are generally healthy. So those odds do decrease as people age and with illness. So people over the age of 67 with a chronic illness are unlikely to be alive even 6 months after that attempt. And that may be not living a good quality of life as well. So I think CPR, it's one of these treatments where I find it interesting that it's the one that we really, really encourage or think is always guaranteed to do us well. And it's not guaranteed to always do as well. There are certain conditions where it is appropriately applied. And for many people, especially as we age and as we plan for a future in case of illness or injury, where it actually might not be beneficial to us. This is up to you to decide with your healthcare team. Um, and so um, what we often see then are these decisions called DNR or DNA CPR. There's different kind of phrasings. Do not resuscitate or do not attempt CPR, that are decided either for a patient or sometimes patients' families are asked to sign these documents, which can be very, I think, very disturbing from the stories that we've heard from families as well. What it does is allowing a person to die without CPR intervention. So these documents are very useful for people for whom CPR would not be an appropriate treatment. So even if you do say, I would, for example, consent to CPR, it may be that your team decides it's not an appropriate treatment for you. And in this case, you might have a document like this included in some of your paperwork. What I would like to say about this is that you can include DNR or DNA CPR in your advanced healthcare directives. And I think people don't know that they can include that there, but you absolutely can. If you've decided for yourself that that CPR is not a treatment that you would like, it is a treatment that you can refuse. And the reason that I would say something to think about is particularly around these decisions are often made for somebody in a hospital setting, and it can be very distressing for other people to have to be involved in that decision. And so if you've decided that it's not something that you would like for yourself, I really encourage you to include it in a healthcare directive so that that's clear. If it is something that you would absolutely like for yourself, to include that as well within a directive so that it's clear for other people. I also want to introduce that there could be other ways that we think about CPR. And as a side note, the HSE will be coming out with guidance, policy guidance on this, fresh policy guidance on this year in the next few months. So we'll have a lot more information on phrasing and different ways that we can approach this. But some ways that have been looked at are things like saying, quote unquote, allow natural death. Now, in my opinion, all death is natural, but there could be some alternative phrasing that we use that doesn't have as much stigma as do not resuscitate or do not attempt CPR. So finding ways to say that we're letting a person begin and go through the dying process without other types of treatment, including life-sustaining treatments, can help to remove that stigma around making a decision like that. It can be more peaceful for families or for supporters, and it teaches us how to support a person differently during end of life. I think on this, when we talk about this, people don't always know what to do when we say uh, maybe CPR isn't right for everybody, for example, or any life-sustaining treatment for that matter. And one time I was training a healthcare setting, and one of the members of staff said, "Well, if we can't provide CPR, what are we just supposed to do nothing?" And I don't think that's ever the case in a healthcare setting, in a care setting. We're always providing people basic care, and it's about learning how to be with people at end of life, and not maybe prolong that moment or prolong suffering as well. So, just offering forward a little bit here for us to start thinking about around CPR, around end of life, and ways that we approach it. And we will have more on this as we work with the HSC later in the year around those new guidance and policy updates. So, I'm going to take a little breath after that. You're invited to join with me, breathing in and breathing out as we leave some of those harsh facts and figures around CPR, around different treatments that you might wish to consent to, you might wish to refuse, and you might wish to sometimes consent and sometimes refuse. Lots of things to think about here. Lots of things to start thinking about. So because of that, you do have a little bit of homework this week. In the file that you have received in the chat, and Mary, if you wouldn't mind to put it in the chat again, we have worksheet 5. This is just a couple of pages for you to start scribbling, start sharing about thinking for yourself about the different treatments, when you would refuse them, and when you would consent to them. So it doesn't have to be a hard line for yourself. A couple of pages there. I think the second page has a bit more space, but you might need some outside pages to kind of start thinking about these things. So you can name any of the treatments, start thinking about where you are today. Would I refuse this today? Would I sometimes consent to this today? Under what circumstances? So you can start jotting those things down. This document here is not a healthcare directive, but it's just a worksheet to help you get thinking about some of those treatments for yourself. Next week, we're coming back to the Decision Support Service. So I just want to give their information out here again. You may have be working away on your EPA. You may need help getting into the logging into the system or getting your ID verified. We do have guidance on those in webinars 1 and 2, but you can always call them or email them for more assistance. We have the information and support line, including via email, support@hospicefoundation.ie, or by calling 1800 60 70 66, 1800 60 70 66. We don't offer clinical advice, so even if you come back to us and you say, "I remember you talking about CPR. Can you tell me if it's right for me?" We can't offer that clinical advice, but we can provide you with signposting and other supports for end-of-life care, advanced care planning, and palliative care, including support for people who are dying at home. You can download the Think Ahead planning pack, including the Advanced Healthcare Directive with QR code there. You can call us. Can't reach that far and still be on the screen, to order your pack over the phone, or you can order it online. And we do have kind of at cost available for many HSC departments and for all nursing homes. You can email us for an invoice as well. And you can always reach out to us, thinkahead@hospicefoundation.ie. Give us a call and check out thinkahead.ie, the hub there as well. All these recordings will be made available there. I am going to end this recording in just a moment, but if you're still here on this live, I encourage you to stick around, answer this post-webinar poll. We'll end the recording and then we'll go into our question and answer session. I know we've raced through lots of things today, so just want to thank everybody for attending. You have this as a resource to go back to now. You have the slides and you'll have this recording. Please bring these treatment options into discussion with your own healthcare team, with your friends and family, so that you can decide for yourself what's right for you. So thank you everybody so much. I'm just going to stop sharing here and